Yeah, Assalamualaikum and good afternoon everyone. I'm Aisha, your moderator for today. Thank you everyone again for your presence at our Immb International Research Talk. So today we are very fortunate again to have Prof. Umberto D'Alessandro, Director, Medical Research Council Unit, the Gambia, MRCG, and Professor of Epidemiology, London School of Hygiene and Tropical Medicine, again with us. So today I will let the IMND Director, AP Dr. Wang Siok Mui, to give a little introduction on our speaker for today.
Good morning. It's my honor to introduce Sorry, I muted myself. All right. Good morning. It's my honor to introduce Prof. Umberto D'Alessandro. Prof is a distinguished epidemiologist with extensive experience in malaria research and control. He graduated in medicine and surgery from the University of Pisa, Italy, and earned his master and PhD from the London School of Hygiene and Tropical Medicine, UK. Prof. D'Alessandro began his career as a clinician in Benin and Kenya before joining the Medical Research Council unit in the Gambia in 1990. There, he led a pivotal evaluation on the Gambian National Programme on insecticide-treated bed nets, demonstrating a significant reduction in child mortality. In 1996, he moved to the Institute of Tropical Medicine in Antwerp, Belgium, where he developed a comprehensive research program focusing on anti-malarial treatment, drug resistance, malaria prevention, and the P-Vivax in vitro cycle. His work has been implemented in several malaria endemic countries, including Uganda, Burkina Faso, Benin, Vietnam, and Peru. In 2011, Prof. D'Alessandro returned to the MRC unit in Gambia as the leader of disease control and elimination team. By January 2014, he was appointed director of the unit and professor of epidemiology at the London School of Hygiene and Tropical Medicine. His current research is centered on malaria elimination and eradication strategies. Please welcome Prof. The floor is yours.
Thank you. Thank you very much. Salam alaikum also, because in the Gambia we say salam alaikum as a greeting. So I'm going to sort of give you an idea of what kind of research on malaria has been done in the Gambia in the last, 70 years, with details of what we are doing now. So first of all, let's talk about, give a bit of information about the Gambia. Here you have Africa, here is West Africa, and the Gambia is just this small strip. This is a map I found in Amsterdam. Is a map of the 18th century. So already at that time, Europeans were visiting the Gambia. So it's the smallest country in mainland Africa, and the boundaries were defined in 1889 with an agreement between UK and France. So the Gambia was a British colony and was surrounded by Senegal, which was a French colony. So the first European to get to the Gambia were the Portuguese, where they arrived. So there is a big river you can see here, River Gambia. They arrived in 1455, and then they gave trading rights to the English merchants in 1588. And the capital was called Bathurst, and now it's called Banjul. It was established in 1816. And there was a British base in McCarthy Island, which is an island upriver in 1823. So with the that the Great Britain abolished slavery in 1833, and some of the slaves that were liberated were resettled in McCarthy Island in other century. So here You have the independence in the Gambia was obtained in 1965. So there were three presidents. Dawda Jawara was the first president. Then Yahya Jammeh, actually, he did a coup in 1994 and he became president in 1996. And then he lost the election in 2016. And then currently we have President Adama Barrow since 2017. So this is the Gambia has this is a strip of land around the river Gambia here. So from the coast to the end is about, I mean, it's more than 300 kilometers. So the MRC unit is here in Fajara, but then we have one field station here in Keneba and another field station here in Basse. So this is just to show a few pictures about the Gambia. Here, very, very long beaches. Here it is, another picture of the Gambia. The sunset, nice on the sea. And also you have the river. So this is part of the river with quite a lot of mangroves on the shore of the river. And this is actually the river in Basse, so the eastern part of the Gambia where we have our field station. And so the Gambia, it's not as nice country, you know, it's called the smiling coast of West Africa, and you can see it's no stress at all. And also we have been lucky enough to be visited by some very famous people. Here is at that time was Prince Charles in 2017. My mother was very happy about that. She was very proud. And then you can recognize here Boris Johnson, who visited us also the same year. All right, so just to say that, you know, we have about 1,500 staff, but these are distributed across the Gambia. So the main campus is in Fajara. We have more than 600 people working there. Then you have here Keneba, the field station, you know, less than 200, and then here in Basse more than 200 staff. But actually, we have also several other staff that distributed across the Gambia in health facilities, for example. In Farafani, I'm going to talk about it. We have a health and demographic surveillance system there. Walikunda, we have a station, entomological station with an insectary here, for example, and with experimental huts. Yeah. So this is the main campus. So you see that you can cross. This is the main entrance. When you cross, you cross the road. You are on the beach. So we have a small hospital with about 40 beds, and we have also 2 or 3 rooms for isolation. We have an insectary as well. We have a data center, so it's a high-performance computing element here. Then we have here the molecular biology lab. Here you have some other labs. Here also there are some other labs, and here on the edge we have some accommodation for the staff. Actually, my house is this one. So I when I have to go to work, you know, it's just 5 minutes walk. Yeah. So how we work is that we are funded. We have what we call a quinquennial review. So every 5 years, MRC UKRI, which is Medical Research Council UK Research and Innovation. So it's the agency for medical research of the British government. They do a review and they provide us with core funding. So core funding means funding for core function, for example, some senior scientists, some core staff, support for running the labs, the clinic, and so on and so forth. But all research is supported by what we call competitive funding. That means research grants. And ideally, according to the success we have in terms of attracting grants, So the platform, what we call the platform, so the labs, other services can expand or possibly shrink. Um, so for this, so basically every 5 years we have to present a report of what we have done in the previous 5 years and also what is our vision for the next 5 years. So this is the vision that we submitted to our funders, the MRC UKRI, for the period 2021-2027. As you see, is formulated to respond to the raising challenges faced by sub-Saharan Africa, which are climate change, migration, rapid urbanization, that all the three of them are going to have a major health impact. So the overarching aim is to deliver research evidence that will generate knowledge supporting the path to longer and healthier lives for all Africa by 2030. And we have specific objectives. There are 4 specific objectives: contribute to the control elimination of infectious diseases, including outbreaks, and this is something that the unit has been done over the years. Decrease the unacceptably high burden of maternal neonatal mortality. The Gambia is one of the countries, with many other African countries, with a very high burden of neonatal and maternal mortality. Address malnutrition, which include also diet-related metabolic disease through discovery science, and then also address the rising burden of non-communicable diseases with special attention to those related to urbanization and climate change. So this is how the unit is structured. Basically there are 3 themes: disease control elimination, you mentioned in the presentation. Then you have vaccines and immunity, and nutrition and planetary health. And we have 3 cross-cutting programs, which are maternal and neonatal health, West Africa, and planetary health. So since 2018, we are part of the London School of Hygiene Tropical Medicine. So here you have different London School centers with whom we collaborate quite closely. You have here the TB Center, the Malaria Center. You have also the Center on Climate Change and Planetary Health. One of our staff is a co-director of this. For example, we have also one of our senior scientists also is involved into this, which is the child health, maternal health, and so on and so forth. You have also antimicrobial resistance center. So all the research is supported by core strategic platforms. I'm going to mention a few, and then you have a very important training and career development department. So this is a bit with the way we are structured with, the unit director. Then you have the research teams. We have the research services divided in 3 clusters: data science, governance, and research support, and then all the labs. Here you have the core strategic platform. I'm going to talk about the genomics and the health and demographic surveillance system. You have the clinical department, so our hospital, and then operation, because we have to ensure that we are self-sufficient. So we have, for example, here the communication, finance, human resources, estates, facility and capital projects, a research operation. We have a research support office as well, and so on and so forth. Okay, so just to say that core strategy platform are platforms that are accessible to all scientists, and they provide a service to scientists to carry out research. Here is this slide just show some of the investment in the genomic platform we did with different equipment that we are able to secure from the MRC UKRI for in the capital bids that we submitted. And so these, for example, we were able, for example, to sequence SARS-CoV-2 lineage during the pandemic. So this is some of the results, and here you have some of the papers that were published. This is in PLOS ONE, and this is in Lancet Global Health, looking at genetic epidemiology of SARS-CoV-2, for example, also looking at the origin of imported SARS-CoV-2 in the Gambia. So the other strategic platform that we have is the health and demographic surveillance system. So basically, it's an area where we record all deaths and births. and also immigration and immigration. And so we have three around our field station. We had a field station here in Farafani that was donated to the University of the Gambia, but we are building now a small structure to host our staff. So basically, West Kiang is a demographic surveillance system that includes something like 18,000 people. Farafani, 50,000 people. Farafani was established in the early 80s. West Kiang also in the late, and then Basse covers about 200,000 people, and it was established sometimes around 2007. So this is Farafani. We have an urban area here, which is Farafani town, and then the surrounding rural areas. So this is the kind of output that we get from this health and demographic surveillance system. Is an example. So looking at excess mortality during the COVID pandemic. So we compare mortality as registered by our demographic surveillance system during the year of pandemic to the previous 5 years. Don't find any excess mortality. Basically, yes, we had COVID, but we did not have that many deaths due to COVID in the Gambia, and this is something that has been shown also in other African countries. So we have also collaboration in West Africa. We have active collaboration with 10 West African countries, and about 20% of our projects involve collaboration with the West African partners. And so, and this is also for research, but also for training. So we have people from other institutions coming to the unit for training. But also, beside that, we have a presence across Africa. So this is Professor Alfred Gua, who is a molecular biologist and looking at the population genetics of malaria, parasites. And this is the network is leading, so the Pan-African Malaria Genetic Epidemiology Network, with collaboration in West Africa, but also beyond West Africa, including Madagascar, Tanzania, Ethiopia. So very important, the strategic approach to training. So we have 4 components: technical and research support skill development. This is mainly for the junior staff. Develop talents through supported pathways, research leadership development program, and then also sub-regional international capacity strengthening initiative. And just to give you one snapshot of the research leadership development program, we have almost 40 PhD students at the moment. So we have an average of 3 full PhD studentship awarded every year from the core staff, for the core funding, and an average of 2 full-time external collaboration PhD. So these are from external grants. So we have also a sort of program of postdoctoral fellowship support to really support early postdoc in going towards independence. So this is our production in terms of publication. So last year we had something like 204 publications. And here you have, about 25% as first or last author. People, the staff of the unit as first or last author. So how we get there is that basically this is the history of the MRC. So it was a military hospital, and it was taken in 1947 by the MRC UK, Medical Research Council UK, as a base for overseas research unit. And its initial focus was on nutrition. So in 1949, there was the director that did research on the role of parasite causing malnutrition. Then I'm going to talk about this survey. There was a survey, I think this was in the 50s, in Canada, where we have the field station neighboring village. So, and then there was a MRC done nutrition unit that was in Uganda that moved in the Gambia. And they took in the 80s the research into our field station. And then we established the other field station for Afeni Base were established in early 80s. So this is a bit the sort of timeline, from 1947. So we had several, milestones. For example, I mentioned the field station here in Bas el Farafani. This is a study I did in the 90s on insecticide bed nets. There was also, I'm going to talk about a study on the now approved by WHO malaria vaccine, RTSS. But we had also worked on hepatitis B. This is the Gambia hepatitis intervention study to look at the impact of hepatitis B vaccine on hepatitis B incidence, but also on liver cancer. This is a study on Haemophilus influenza type B vaccine, studies on pneumococcal disease, also study on pneumococcal conjugate vaccines. The Gambia actually eliminated trachoma recently, and there were quite a lot of research that supported that achievement. So there's quite a lot of studies that really support public health interventions. But so what's the link in terms of research? The research in the Gambia for example, started in 1902. There was an expedition of the Liverpool School of Tropical Medicine, led by Joseph Everett Dutton. So we identified the Trypanosoma gambiense. That's why it's called gambiense. So it's the parasite for sleeping sickness. So the it was described was in the Gambia. It was identified in the blood of a captain on the Gambia River boat. And then also look at, so there was a hospital called Royal Victoria Hospital. This is in Banjul, in the capital, examine the records of the patient admitted in the hospital and show that malaria was a major cause of hospitalization and death. And these are results of a survey that was done at that time. And you can see how the prevalence of infection, in children under 5, 82% of them had malaria. And then it increases to 91% in children between 5 and 10 years, and then 54% in children 10 to 15. So there were several parasites. At the time, we were called Immb precox, Immb malaria. Then the name was changed to Plasmodium falciparum and Plasmodium malaria. But also the vector was identified as Anopheles gambia. So the reason why one of the vector, which is found across Africa, is called Anopheles gambia is because it was first described in the Gambia. And so just to say that, Ian McGregor was the director for 2 periods of the unit. He did a survey in Canada, where we have a field station. And, again, these surveys show a huge burden of disease in the local population. So high malaria prevalence, but also you had Bancrofian filariasis with elephantiasis. There were 16 cases of trypanosomiasis, sleeping sickness, 50% of hookworm infection, the children, adults. There was leprosy, trachoma, use, quite a lot of malnutrition, and also outbreaks of measles and whooping cough. So, but the situation in the Gambia, the situation in terms of health in the Gambia has improved quite a lot over the last, 100 years or almost 100 years. So here is the under 5 mortality per 1,000 live births. You see that in the 50s, this was very high, more than 400 per 1,000 live birth. These are results from different censuses done in the Gambia. You see that has gone down, and these lines are the mortality rate that have been calculated thanks to the data collected by the Health and Demographic Surveillance System. You see that there has been a substantial decrease over the years of childhood mortality. And this is data from our Health and Demographic Surveillance System in Farafani. In terms of childhood mortality, you see that these are the overall child mortality. this is the infant mortality, and this is the neonatal mortality. You see that it has really gone down substantially over the years, while neonatal mortality is still a problem. There is still a lot of neonatal mortality and it hasn't really changed over the years. So this is why we have this focus on maternal and neonatal mortality. So just to go back to malaria and also the historical results, the cannibal survey, it was shown that the malaria prevalence decreased with age. This was one of the first indication that there was a development of partial immunity. So as you get exposed, your immune system develop an immune response, and it makes you more or less partially immune to malaria. And this is so following this is Jan McGregor. This is the results of an experiment that today would be almost impossible to do, because what he did, he took serum from adults, Gambian adults, and then injected it to children who had malaria. And this is the evolution of parasite density after injection. You have here the untreated, so not much treatment. You have the control, so they were injected with gamma globulin from UK. And this is the evolution of the parasitemia in a child that has been injected with, in children that have been injected with gamma globulin from adult Gambians. And this shows that, humoral immunity, it's important for protecting against malaria. And not only that, so he also did the same things with serum from Gambian adults in children in East Africa. See, these lines are the parasitemia in the children in the Gambia. These are the children, East African children, who were injected with the gamma globulin from Gambian adults, and also this one. And these are the control. And so basically, you can see that for some of them, they had exactly the same evolution that observed in the Gambia. Others that had a decrease in parasitemia, but then after a while, the parasitemia increased. So basically, it showed that antibodies to malaria had both cross-strain, because they could control malaria transmitted in East Africa, and also a strain-specific component, although not complete, because in these children, parasitemia went up again. So again, this is a study that wouldn't be possible nowadays. But so this is really what show that it is possible to get protective immunity, and so this data show that a vaccine is potentially feasible. So this is coming to the 90s. This is I don't know if you remember, for those who have worked on malaria, this is a vaccine called SPF66 that was sort of developed by a Colombian scientist, Manuel Patarroyo, who claimed that this vaccine was really working. And so we actually did a clinical trial. This is me in the 90s. This is Professor Brian Greenwood. And this is Professor Jeff Target, and this is the field staff. So we look at, the safety efficacy of this vaccine in Gambian infants. And unfortunately, we didn't find any difference. But, this trial sort of provides a lot of information on how to how to implement a phase 3 trial for evaluating malaria vaccines. And this is the first sort of, I say that, the first, actually, this is the, is the earlier version of the presentation. I should have given this at the later stage, but anyway, this is fine. This is the first vaccine, RTSS, but the first version with a different adjuvant, ASO2, This is a vaccine produced by GSK. My colleague Khalifa Bojang did the study looking at the effect of this vaccine in semi-immune adult men in the Gambia. This was done in Bassi, in one of our field stations, the eastern part of the Gambia. And you can see that the probability of remaining free of parasitemia, this is the vaccine and this is the control. So there is a difference for a certain period, but then the line also get together. And if you look at how the protection, so the overall protection is below 50%, but in the first 9 weeks, it was very high. Then the following 6 weeks, almost zero. And then if you give a booster dose, you have, again, some protection. So basically, it worked, but it was a protection that was short-lived. So let's now talk about the bed nets, the early trial on bed nets. So the Gambia has been a place where there's been a lot of studies on bed nets. These are the first studies looking at the protective efficacy of untreated nets with insecticide at the individual level, and nets with insecticide at community level. So you have obviously an increase in protection. If you look at the individual protection at community level protection, this is a study that done by Bob Snow in the 80s. This was followed by a large trial on bed nets, looking at the effect of bed nets on childhood mortality. The study was done by Pedro Alonso. And here is the intervention villages. This is the number of deaths. You see the before intervention. You have a classical peak of deaths in October, November, but the following year, after the intervention, I mean, you hardly have any deaths. While in the control villages, you have this peak, the previous before the intervention, and you have the similar peak after the intervention. And so this was followed by the study I did in the Gambia. So the previous study that done by Pedro Alonso was a trial, although it was not randomized. But this one, the one that I did is the evaluation of the National Bednet Program, in which villages were provided bed nets by the National Malaria Control Program, and other villages were not provided bed nets. So actually the implementation was done in 2 phases. 1 year, half of the village across the Gambia were given bed net, and the following year, the remaining villages were given bed nets. So, and here are the results of the first year. In Blackie, we have the untreated villages, and in white, the treated villages. And you can see that there is a difference at the peak transmission between treated and untreated village. Actually, if you go and look at the reduction of mortality, there is a 25, as mentioned before, 25% reduction in mortality, all-cause mortality, not only malaria, all-cause mortality in children below 10 years. But then in the Gambia, we did also many other, not myself, but the unit did many other trials on other vector control intervention, house screening, for example, larviciding, also looking at the additional effect of indoor residual spraying, so spraying insecticide in the wall, and bed nets. This is long-lasting insecticidal nets. Actually, they didn't find a difference between long-lasting insecticidal nets alone and long-lasting insecticidal nets and indoor residual spray. So basically, indoor residual spray didn't add anything to the effect of bed nets. The unit has done also trials on treatment of malaria. It was a place where the first trial on artemisinin derivative in severe malaria in Africa was done by Bouleva Esbrook at the teaching hospital in Banjul. And here you see the level of parasitemia in children treated with artemether or with quinine, so quinine and artemether, you see that there is a difference between quinine and artemether. It was the first trial showing that an artemisinin derivative was better than quinine. And also the first trial on coartem, so artemether lumefantrine, this is artemether lumefantrine, done by Lawrence von Sedling in African children with uncomplicated malaria. And also, beside treatment, there have been studies on chemoprophylaxis. So this is a study that has been done by Brian Greenwood, who was the director of the unit between 1980 and I think it was 1995. I was actually, when I went to the Gambia the first time in 1990, he was the director, he was my supervisor. So this is a study that he did looking at the effect of maloprim, which is dapsone chlorproguanil, if I'm not wrong. So that was given every fortnight to children, 3 to 59 months, fortnightly, and looking at the number of deaths. Definitely the chemoprophylaxis reduce the risk of clinical malaria, but also there is suggestion that they decrease also mortality. If I'm not wrong, so we have here 1.5 per thousand deaths per thousand children years, and in the chemoprophylaxis group, and 10.4 per thousand children year in the placebo group. And if I'm not wrong, I think the size of the trial did not have power to show a significant difference, but obviously, you see that the difference is very high. So the Gambia, in the meantime, there was a substantial decrease of malaria transmission. You remember that at the beginning I told you that in the 50s, something like 80-90% of children were infected with malaria. Here is a study that was done following the records of the health facilities. This is Bansang, this is Basset, this is Bansang. These are two facilities in Eastern Gambia, different years here, and then you have the column here is the black one are the positive slides, and the white one are the slides taken. And you can see that from 2003 to 2009, the percentage of slide positive has decreased substantially, as shown here on the right side, both in Basse and in Bansang. So malaria has become really transmission has decreased substantially, probably thanks mainly to the insecticide-treated bednets. But so when you have a place with very intense transmission, and then you reduce transmission, like you show here, you don't see the difference because transmission is so intense. When you reduce transmission, you see that there are a lot of rocks in this case, but a lot of difference between different villages. So the transmission becomes increasingly heterogeneous. And so this is the actually relatively old slide of Senegal, with the prevalence of infection in Senegal. The Gambia is here, is the mouth of Senegal, if you want, is smiling Senegal. But basically, you have in the north very low prevalence of infection. Here you have moderate prevalence of infection, and here you have relatively high prevalence of infection, with the line that crosses the Gambia at this level, central Gambia at this level. Well, we did a study in the Gambia. This is Julia Mesigua, was my PhD student. She's now in Uganda. Where we look at 6 sites, and each site we have 2 villages, and in each village we took a blood sample from the whole population during the transmission season. So these are the different months during the transmission season, which it goes from June to December. And then you had also one survey during the dry season, this is April. So you see that it's very there is a line that crosses the Gambia that corresponds exactly to the line that you show in Senegal, where you have in the Western Gambia, you see that the prevalence of infection does not change much. The darker boxes correspond to patent infection, so the infection that can be detected by microscopy, and the lighter boxes correspond to subpatent infection, so they can be detected only by PCR. And you see that in this in Western Gambia, you don't have much change in prevalence of infection during the transmission season, so it just wobble around 5 to 1%. But if you go to Eastern Gambia, we have still the classical peak, I mean, that goes up to 25, 30, 40% here. Here is a bit less, it goes up to 50%. So it's the similar division that stratification that we find in Senegal. So, and also we look at the different vectors, and you can see that, for example, the composition, we have different vectors corresponding to Anopheles gambia complex, because the Anopheles gambia complex includes several subspecies: Anopheles arabiensis, Anopheles coluzae, Anopheles gambia sensu stricto, and so each of them have a different behavior. And for example, Anopheles arabiensis more bites more outdoor, while Anopheles coluzae bites more indoor. And you see that the composition across the Gambia, so A, B correspond to this one, and then you have D, it's here in the North Bank, and then E, F, it's also in Central Gambia, and then G, H, and G, it's exclusively Anopheles coluzae, it's here in Central Gambia, North Bank, and so on and so forth. So you have a difference in prevalence of malaria, but also a difference in the vector composition. This is Kevin Opondo, also another PhD student, Kenyan, who finished his PhD and is now in Sierra Leone. And so also we could, with this project, we could also look at the genetic profile of the parasite and try to understand how the flow parasite between East and West. This is Professor Afrengua, who did most of the analysis. And if you you have different slides, each slide correspond to a month: July, August, September, October, November, December. And so the red, so we compare the genetic profile, the barcodes of parasites in the Western villages with those in the Eastern villages. And you see that the flow parasite mainly from east to west here. So here is without taking into account travel history on the top slide. And here take into account travel history. And you see that quite a lot of infection that are found in the western part of the Gambia are probably originating from the eastern part. So this is the last, one of the last large study that we did. We actually evaluate the mass drug administration of ivermectin and hydroartemisinin piperacin against malaria. So it's a cluster randomized trial. So we basically randomized villages into intervention control groups. And just to make this long story short, here is the difference between intervention control village. We have a decrease of prevalence by 60%, and also a decrease of incidence of malaria by 80%. And also we are able to see, because ivermectin is an endectocide drug, so in principle, vector that bite treated people have, the blood is insecticidal, so the vector should die. And we observed a lower vector density in controlled village and a lower entomological inoculation rate in intervention village. So going back to vaccine, and very briefly, so this is the two studies that we are doing now. This is the VAC86, it's a phase 1B, first in human, of a combination of R21, this is the malaria vaccine already approved by WHO, with a new antigen, which is RH5.2, which is antigen against blood stages. And we have here 9 groups in which we have a sort of age escalation, dose escalation. So these are the infants where you're given only R21. Then you have adults. This is first in human. So with RH5.2, first at 10 microgram and then increased dose of 50 microgram. And then adults with a combination of R21, RH5.2, and then if the vaccine is judged safe, then we pass to infants, RH5.2 alone, and then RH5.2 together with R21. So we are at this moment, we are actually at this level. So we have done up, we have implemented up to group 7. So in the next few months, we are going, if the safety results are fine of this, in the group 5, which is the combination of the 2 antigens, then we are going to start these groups that are infants with the combination of R21 and RH5.2. So the other study that we are doing now as we speak is this one, seasonal R21 mass vaccination for malaria elimination, and basically really it's just to see whether R21 administered to the whole population can reduce transmission. So it's really to compare intervention control cluster. In intervention control cluster, the prevalence of malaria at peak transmission after seasonal mass vaccination with R21. So these are 3 monthly doses. And here we have several secondary objectives: safety and tolerability, incidence of malaria infection, and incidence of clinical malaria. So there is also next year, there is a booster dose in which we are going to look at the same endpoints. And then as exploratory, we are going to look at also at serological markers as a way of detecting changes in malaria transmission. So it's a multi-center study done in the Gambia, Burkina Faso. It's a cluster randomized trial. We have villages randomized to intervention control group, and all residents in intervention village have been vaccinated before the malaria transmission season. So between May, July, and August, we vaccinated all the residents. And as I mentioned, there is a booster dose for next year. But all villages receive standard control measures, which are insecticide bed net, indoor residual spraying. This is seasonal malaria chemical prevention and also intermittent preventive treatment in pregnancy. So this is the power for the prevalence reduction. So this is Burkina Faso for 12 villages per hour, and this is the Gambia for 15 villages per hour. So we have 80% power to detect roughly 45% reduction in prevalence. And we have a cohort of 30 individual per village in the Gambia and 20 individual per village in Burkina Faso, who are going to be bled every month to look at the incidence of infection. And so this will give us 80% power to detect at least a 38% reduction in the incidence of infection. So that's where it is done in Burkina Faso and in Burkina Faso here and the Gambia. And this is the results of the baseline that we did in November last year. In red, you have the prevalence of Gambian villages. In blue, the prevalence of Burkina villages. You see the difference. In Burkina, you have something like 78% in villages with a prevalence of malaria of 78%. In the Gambia, goes from 5% to 30%. So in the Gambia, we surveyed 45 villages, and out of the 45, we choose 30, so those with the highest prevalence. And similarly, in Burkina Faso, they surveyed 30 villages, and out of them, they choose the 24 with the highest prevalence. So this is just the randomization showing, we randomize the study villages we show that quite a good balance between intervention and control, and the same in Burkina Faso. And so the entry criteria, basically, we vaccinate everybody who aged 5 months or more, and we have several exclusion criteria, including pregnancy. We don't vaccinate pregnant women. And so, yes, this, as I said, is ongoing. We are now doing a passive case detection, so detect the clinical cases of malaria, and we have started the monthly blood sample collection. And so we have a cross-sectional survey planned for November this year and November next year. And I think this is the last slide. Yeah, just no, it's not. This is the arrival of the vaccine in Basse, with the box, full box there. And then the preparation in the cold room. And then this is how we do the vaccination in the village, in the villages. So these are some of the images, preparation of the vaccine and the vaccination. And I think this is the last slide. Thank you very much for your attention.
We have some questions from the online audience.
Sure. Okay. Yeah, for the, shall I do start? Or no. What? Okay. How about manpower on MARG? Oh, MRCG. So the unit has got 1,500 staff. 80% of the staff is Gambian. But there is, so the rest is international. Mainly, there are Gambians as well among senior scientists. For example, Professor Alfred Ngwa is from Cameroon. So the statistician for the study I mentioned, the vaccination study, is Nuruddin Mohammed, who is Ethiopian. So we have quite a lot of staff from Africa, and then also from outside Africa. What about snake bite? No, I mean, we don't have antivenom produced in the country. It needs to be imported. We don't work on snake bites, but I guess this may be something that could be a problem. To be honest, I don't know if snake bite is a huge problem in the Gambia, but yeah, we have snake bites from time to time. And also the methodology. Yes, the methodology. So what we did, Alfred did, is he used a sort of different SNP in the genome of the parasite to produce a barcode, and then that's what it was done. The comparison of the barcode between infection in the West and infection in the East. I think that's the last question I have. So I don't know.
From the physical participants, do we have any questions?
Yeah.
Thank you again for amazing sharing. So actually, I have a few questions.
Sure.
It's the first one. It's not really complicated. I just feel like fast. If I'm mistaken, you said just now the Gambia is one of the smallest country in the African continent, and from what you shared, based on malaria itself, there are many research related to malaria. I need to mention any other research. So how do you find the complement, or maybe how do you find the recruitment of the participants? Is it easy, or maybe you have some engagement for this?
Yeah, of course. Yeah. So I mean, all these things, all this research needs to be done in full collaboration. First of all, with the Gambian authorities, Ministry of Health. We are based into the health facility. Some of the studies are based in health facilities, so we need. So all these studies have to go through ethical review, approval. We have, in case of testing a product, there is a medicine control agency, which is the regulatory authority. So the MCA, the medicine control agency, has to approve the trial, has to approve the importation of the product. And also, after ethical approval has been given, we ask the Ministry of Health to provide us the permission to work in their health facility. So this is from the side of the authorities, in terms of the population, you can't go there and just start research. So you have to discuss, you have to meet the people. In the case of the trial, the last trial I show, there was a preparation. We had a workshop in which the chief of the villages and other people, important people of the villages involved, are invited. And we discuss the project. We hear their concerns if they have any. So it's a long preparation, because otherwise. But we don't have a major issue in terms of recruitment. The MRC has a very good reputation in the country, and obviously you have always people who refuse to be part of the studies. I mean, the main issue when people refuse is really the blood collection. They don't. I mean, nobody likes to have blood collected, so that may be one of the issues. But in this case, in most of the malaria studies, it's a finger prick, and so usually most people accept that. If it's instead is venous bleeding, it's much more complicated.
And actually, another question is like because I can see that Prof is involved in many vaccination program and immunization trial. And in your opinion, in malaria itself, will herd immunity play a role for malaria elimination, maybe? Or in your opinion, is it going to work, or is each and every one of the people need to be vaccinated?
Yeah. Well, we are doing a study because we hope it's going to work. Yeah, I think it's possible that it will work, because what we would like to, because the vaccine has been developed for children, and the recommendation of WHO is to vaccinate children through the API. But of course, you can't have a mass effect in children, and also you have to consider that in the Gambia, the group at higher risk of infection are older children or adolescents. So the smaller children are in a way protected by bed net, by seasonal malaria chemo prevention. So seasonal malaria chemo prevention is full treatment, monthly treatment given during the transmission season. Usually it's sulfadoxine, pyrimethamine, and amodiaquine. So all children 3 to 59 months are given this treatment, starting, I mean, in the Gambia, they start at the end of August. So August, September, October, November. So they receive this. So in a way, the children under 5 are really protected from malaria, and very unlikely they're going to go towards severe malaria and death. But so in the but you have the group at high risk is children older than 5 and adolescent. And so we think that if we are able to vaccinate most of the population, and there are mathematical models that are showing that, predicting that, because there are mathematical models. Actually, there is a component of mathematical modeling into this trial I didn't talk about. So all the mathematical models show that if you vaccinate, have a coverage at least 50, 60, or 50%, you must have an impact. You should have an impact on transmission. So this is exactly what we are trying to show with this trial. Yeah. Have you considered using a similar formulation as the previous medication used previously for malaria? For example, Artequick. So earthquake, if I'm not wrong, is artesunate. I don't remember what's in earthquake, to be honest. But I mean, I guess the question is about mass drug administration. So I think so the mass drug administration, uh, is not recommended by WHO as an intervention, except in certain cases. And the reason for this is that in most cases of mass drug administration, the effect has been transient. So you reduce the risk of in the prevalence of malaria, but once you stop, it just goes back again at the same level. Yes, mass drug administration. That's right. So yeah, mass administration can work in certain conditions, and I think we have to use the different tools that you can use according to the situation you are facing. So in this case, we did mass drug administration. We did artemisinin, piperaquine, and ivermectin, and it shows a major impact because you had the decrease of prevalence by 60% and the decrease of incidence of clinical malaria by 80%. The problem is that people also, so it's difficult to maintain, and also the effect is transient. So it just goes back again when you stop. And also people, if it lasts for too long, are less and less ready to be treated. There is a bit of reluctance. So it can be used for in certain conditions, but it's not the answer that it's not something that you can use everywhere.
Any more questions?
Yes.
Thank you. I just have a question. Mentioned on the I was wondering whether it's specific to different types of agent and you have
Yeah. So the question is whether the vaccine is active against all species of malaria or on a certain species. So the vaccine is for Plasmodium falciparum because in the Gambia, most, if not all, cases are due to Plasmodium falciparum. So we don't have a vaccine for Plasmodium knowledgeae. So.
One more question.
Yes. Yeah. Okay. So the question is about other diseases. So yes, we work on different diseases. For example, I mentioned the pneumococcal diseases. So there's quite a lot of work that has been done on pneumococcal conjugate vaccine, for example, and there is a trial that just finished recently, whose results are not out yet, that compare 2 doses versus 3 doses of pneumococcal conjugate vaccine. There is, we work on neonatal sepsis, for example. So there is somebody working on diarrheas, rotavirus, for example. So there are several other diseases we are working on. The vaccine and immunity theme is doing quite a lot of work on vaccines. So there is some work ongoing on HPV vaccine, for example. So but it would have been too long to explain to explain all the things we are doing. Yes. But not on trypanosomides because we don't have cases of. You know what? No, it's not the most prevalent. Malaria was important. So this is why, and thanks for the presentation. The issue is at this moment is how how you achieve elimination, how you interrupt transmission. So the level of malaria is low, transmission is low compared to 10 or 20 or 40 years ago, but they're still there. There's still residual transmission. And so even if the burden is not as high as before, and maybe there may be other diseases that are more important, if you want to achieve elimination, though, so you have to make an extra effort, even if if the burden is not that high. See what I mean? Yeah.
Prof,
Yeah.
question. What about the dosage, the vaccine for children and adults? Is it the same? And what is the interval? The first dose, second dose, the third dose. What is the interval? And does the children need booster?
Yeah.
For the
Yeah. So the dose is 5 microgram of the antigen for the children and 10 microgram for the adults. And the dose are given at 1 month interval. Yeah. Yeah. So this is, all these things are in a way a bit, arbitrary, because these are based on data from phase 1, phase 3 trials. So actually, if you remember the phase 1 we are doing on the R21 RH5.2 combination, there are groups that are given the vaccine at month 0, month 1, and month 6. So just to see whether, is it the 3 monthly dose necessary, the best option, or should we do a dose, the third dose after 6 months, delayed dose. So there are still questions really. But for the time being, we do 3 monthly doses. Yeah.
one more additional question.
Yeah, sure.
Like, where are we now? Let's say if the vaccine works, how soon it will be in the market?
So the R21 is already in the market.
Okay.
It's already approved by WHO, pre-qualified. In some countries, it has already been approved. For example, Burkina Faso, I know, Ghana, Nigeria. The regulatory authority has already approved the vaccine for use in the country. I guess we would need to present the documentation for adults. The other things, probably one trial would not be enough for the recommended. This is the first trial. There is Lawrence von Seidelin, who is based in Thailand, who is preparing also a trial on mass vaccination together with antimalarial treatment in Bangladesh. So they're going to, if the results are positive, then they're going to be probably a few more trials to confirm. Then afterwards, this could be included into the policy if it works. Yeah.
Okay, I think that's all. Thank you very much, Prof.
Thank you. Thank you for the
Umberto.
listening.
Thank you very much, Prof. Umberto D'Alessandro, for the very informative talk today and also yesterday. We are very thankful to have you here, coming all the way to Malaysia and also IMB. We are honored to have you here. I would also like to thank the physical as well as the online participants for joining. We will have another online talk next week, Wednesday, so please do come and join us. With that, I'm going to end today's session. Please have the refreshments outside. Thank you.
Thank you.